So the next topic of argument was going to be dealt by Dr. Rohit Om Prakash, who heads Dr. Om Prakash Eye Institute, a surgeon of international repute, very innovative and brilliant surgeon, and he's going to talk on RHEXIS extension in PHACO. Proceed with PHACO is what Dr. Rohit Om Prakash is going to talk, and countering him is our ever popular, extremely efficient and an amazing surgeon, Dr. Ragini Parikh, who heads the ophthalmology department of JJ Eye Hospital, Mumbai, with a record-breaking number of surgeries to a hilt, with her set of arguments as why she would not do when the RHEXIS extension has happened, and she would convert to MSICS. So let's hear both of them.
Is my
Yes,
slides visible? Yes. And am I audible, adequately audible?
Yes, yes.
Yeah, thank you, Dr. Chitra, for this opportunity. So my topic for the day is whenever there's a RHEXIS extension in PHACO, so what should be the option which we should be doing? So suppose whenever these anterior capsular tears, they do happen in quite a number of patients. And whenever these happen, we are in the crossroad of surgical dilemma. And this crossroad of surgical dilemma is there because at times we are able to complete phaco emulsification, whereas there are other times we end up with a situation wherein we have complications. So this is a situation which wants that should we continue with phaco or should we convert to manual small incision cataract surgery? Well, why is the surgical dilemma there? It is simply because of the fact, because whenever there is an anterior capsular tear, we are not sure about the extent of the anterior capsular tear. So that brings in uncertainty. And if ever it extends onto the posterior capsule to become a wraparound tear, there's a time lag for the appearance of signs of posterior capsule rupture. And by the time you realize it, you end up with a situation which is full of complications. And the surgeon variability factor is there, wherein novice surgeons have a bigger time lag to really appreciate the wraparound nature of the tear. So what should be done? So the concept was that should we proceed with phaco, wherein majority of anterior capsular tears remain pre-equatorial, because of the barrier created by the relatively thickened anterior capsule in the mid-periphery and the zonal attachment on the peripheral anterior capsule? Well, we should say that if we have to move with the anterior capsular tear, there are a number of complications. 24% PCR, vitreous loss is there in 16%. And well, I'm speaking for Dr. Ragini for some time here. And all these complications are there. As you can see in this also, the critical patient safety incidents, unplanned surgical readmissions and everything are as high as 27%. So what should be done? Well, the answer is a big no till now. Well, 2017 changed the scenario. We came out with a flap motility as a sign of posterior capsule rupture in peripherally extended anterior capsular tear. And this, what we found was that if the flap was fluttering, the posterior capsule rupture was 0%. Next, what was the relation of posterior capsule rupture with inverted flap? It always happened. So keeping these things, and then we had a follow-up study of 119 patients with pre-equatorial flaps. So all pre-equatorial flaps did not have extension onto the periphery, onto the posterior aspect, forming a wraparound tear. And those with post-equatorial flap with inverted had validation, which was as high as 100%. So, but the most important point was that we came to know when was the end point of safe phaco emulsification, which I would go into later on. So let's see this. You will find the first thing when an anterior capsular tear, you will find when I use the visco, the flap this is everted now. This is fluttering. So this shows it is pre-equatorial. And see the site of incision. It is not in the same plane as the extension is. The separational forces have to be minimal. They have to be in the direction of the anterior capsular tear. IOP is on the lower side, low fluidics have to be used, and the separational forces have to be minimal. So when you use and you can see the flap fluttering. So if by any means there is an anterior capsular tear, and if you can see the fluttering flap, there is no need of stopping with phacoemulsification and converting. You can continue with phacoemulsification without any issue whatsoever. You will find that still the flap is everted and fluttering at this point of time. And the next point is try to, so that there is less pressure in the interior, in the intracapsular phase of the phacoemulsification, try to do supracapsular emulsification if you can. Since it was a softer, not so hard cataract, I continued. And at this point of time, you will also find that what is happening is the flap, you would find it is still everted and fluttering. So if the flap is everted and fluttering, keep the chamber stable as I did in this. The flap is still fluttering and everted. This shows that it is preequatorial. So dear friends, if you believe in flap motility sign, you can very well continue with phacoemulsification if the flap is everted and fluttering. And the IOL can also be implanted in the bag without any issue. And while I'm doing this, sub-incisional cortical aspiration, you will find that the flap is still everted and fluttering. So this showed
1 minute remaining.
Yeah, so this is what it is. And the next is endpoint of safe phacoemulsification is also very important. You will find that here the flap is fluttering. The moment it stopped fluttering, that is the endpoint of safe phacoemulsification. That is the time when you should convert to what Dr. Chitra wanted, that you can convert. So that is the only condition. So key points to proceed is you should appreciate the flap motility sign. Your site of location should not be in the axis. You should use low fluidics, stable chamber settings, guarded separational forces. Direction of separation is very important. Keep a vigil on the flap. You should know what the endpoint of safe phacoemulsification is. And when you feel you are there, then you should convert to manual small incision cataract surgery. This is what the plan of action should be. Convert if you see that the flap is not everted and fluttering. Complete phaco if you can, when you're proceeding. You should know what the endpoint of safe phacoemulsification is and convert when required. So ignorance is bliss, little knowledge is dangerous. Let us learn, unlearn, and relearn. Thank you very much for your kind attention.
You're muted.
Sorry, thanks a lot, Dr. Rohit. That was an amazing talk as expected.